Well, welcome to the latest edition of the St Mark's podcast, coming here from St Mark's in Harrow in West London. My name's Peter MacDonald, and I'm interviewing today Professor Omar Faiz, who's one of our surgeons here with a keen interest in inflammatory bowel disease and an expert in that. He's also our clinical director. And welcome, Omar, to our little program.
Thank you very much, Peter.
And I was thinking, we're talking about inflammatory bowel disease. We're particularly talking about, I think, ulcerative colitis today. We might touch on Crohn's disease, but I think it'll really stick with ulcerative colitis. As a surgeon, a proctologist like you and I always used to think that I got the simplest cases as well as the worst cases, in the sense that they'd present sometimes with rectal bleeding, a little bit of discharge and pus and diarrhea, and then we would treat those for a little while if we could, and then pass them on to the gastroenterologist when they needed more treatment. And it was only when all that failed that we got them back again. So we always saw the easiest and the worst. Make a comment about that?
It's interesting you say that. I think we're possibly, it's going further than that now. I think if anything, we're seeing the worst now. I think many of us now are outside of the endoscopy department, so we're not necessarily scoping, and a lot of people don't have a proctology practice such that they're necessarily seeing the rectal bleeders firsthand. So I think for the majority of colorectal surgeons, they're encountering ulcerative colitis patients either as part of their emergency on-call work, when there's a colitic on the ward, or through their elective work if they also sort of cover an elective component to inflammatory bowel disease surgery.
So thinking about, first of all, the elective component, the three main indications of surgery or total colectomy for ulcerative colitis is, of course, someone who's already got a cancer, someone who's got dysplastic changes, and the majority are those that have failed medical management. We're not going to discuss that in detail, but is that roughly how you see it? Those are the three main indications.
Certainly in the elective setting, you're absolutely right. I think the problem is that the definition of failing medical management now is becoming more elusive, really, and there are more and more treatments that patients can try. So I think sort of patients are in that area for longer, and there's always a blurred distinction between those ones that actually limp to see you in clinic and those ones that are actually admitted through the gastroenterologists with colitis.
And you sort of hinted for a moment there about the new medical treatments. I mean, have the new biologic medications reduced the colectomy rate overall in this modern era?
It's a really difficult question to answer. I would have thought that we would have had a definitive yes or no for that by now, but we don't. We've certainly in the Western world, we've always quoted figures for patients who've asked in the region of 20 to 25% lifetime risk of undergoing a colectomy. Now, the majority of those patients will tend to have their colectomy early on in their disease, usually within about 3 years of diagnosis, and about a third of patients actually fall after that timescale. What's been quite difficult to ascertain has been whether or not those changes, whether or not the colectomy rate has changed. And if there are changes within certain populations, are they directly attributable to the introduction of biological treatments? Now, you see, I mean, going back 10 to 15 years, there was evidence emerging out in Canada to start with that actually after the introduction of infliximab, you could see a reduction in the rate of elective surgery for ulcerative colitis. Now, that doesn't necessarily follow that it was the introduction of infliximab. There are a lot of things that were changing around that time. And that hasn't been substantiated by everybody who's looked at this. You've got other areas, other investigators who've looked at other populations, and actually the colectomy rates have, if anything, gone up. Others have found that colectomy rates were actually coming down anyway, and so trying to actually sort of define that it was attributable to biologics just isn't possible.
And of course, we at St Mark's, it's difficult for us to say from our own figures because obviously we've got more surgeons than we used to. We've had more referrals, so it's difficult to.
We've got a complex picture because of the tertiary referral practice. We've got some data which we've presented from the national hospital episode statistics data for England on this, and this is work that one of my PhD students, Guy Worley, has done. And this looks at the colectomy rates for elective surgery and emergency surgery for ulcerative colitis in England, so across all NHS hospitals. And what we can say from that is that colectomy rates have dropped a little, but not hugely. And that's really only over the last few years. The reduction has been about 4% per year.
Really quite small then.
It is quite small, and it's again difficult to attribute that directly to biological therapy. So, has there been a change? Well, there may have been subtle changes, but we certainly haven't found big seismic shifts in the management of ulcerative colitis due to the introduction of these agents.
Okay, thank you very much. Now, who should be performing this surgery? Obviously, in the emergency setting, any good abdominal surgeon should be able to take out a colon in an emergency setting, and we can't expect the elective centres to be able to do all the emergencies. It just wouldn't be practical or safe. But who should be performing the elective operations?
Don't know the answer to that, Peter. Who would you like to do your elective operation?
The right surgeon, the right place at the right time, but that's begging the question. What
if the wrong surgeon thinks he's the right surgeon?
There's another problem. But what about the evidence for high volume centres and the patient outcomes? I mean, take something like ileoanal pouch, which is a complex operation. Just take that alone.
So I think this is a really important area, and you have to look at the patient pathways in all of this. Because how we configure services is very, very different, and what we can offer in terms of the emergency pathway and what we can offer in the elective setting. Now, certainly in the emergency pathway, a patient will follow their gastroenterologist usually into hospital under their direct admission. And then the gastroenterologist will call upon their colleagues, their surgical colleagues, for support. And again, the on-call rotas that exist out there in very tertiary centres, you've got exclusive colorectal on-call rotas like we're very lucky to have here. But you go to other places and they have to be a lot more general. So you may not have, you may have a very sort of broad GI specialist on call. In other places, you may not even have that. It may actually fall to the breast surgeon to undertake the colectomy in an extreme situation. Now that's very different, obviously, and that the approach to that requires complete reconfiguration of services if we're going to change some of that. But what can change much more easily is what happens to the patient after the colectomy. I think it's important to say that if it was me, Peter, I think I would want a laparoscopic colectomy. At least that would keep me in the running for a laparoscopic restorative procedure thereafter. And you would hope that sort of most centres would be able to sort of feel that today. But it's not easy.
In the acute setting.
In the acute setting, it's not easy at all.
Well, let's just talk about the acute severe colitis, which is the term which is to some extent replaced all those other lovely words like toxic megacolon and fulminant colitis and all those beautiful sounding, terrifying words that we used to use. So we're talking about acute severe colitis. And about 20 to 30% of patients might present this way initially. Yeah. How do we define it exactly? I know there are lots of scoring systems and this and that, aren't there?
So it is it's done on the basis of certain clinical and biochemical parameters. So a patient who has acute severe colitis on the True Love and Wits criteria, it will be decided on the basis of the fact that they go out to the toilet over 6 times per day. They will have a temperature over 37.8. They'll have a tachycardia, defined by a pulse rate of over 90, a hemoglobin under 10.5, and I'm sure there's one other, but I can never get all of them.
CRP,
Yes,
over 30.
an elevated CRP over 30.
So this is managed initially with the help of the gastroenterologist, obviously, as well as the surgeon keeping an eye and waiting for the moment that things may change, with steroids, hydrocortisone still the mainstay.
Yeah, so various different guidelines have come out this year in the UK, and it's still very much the admission is likely to be led by the gastroenterologist, and for the first 3 days they will commence the intravenous hydrocortisone, usually 4 times a day. At the same time, they'll undergo sort of daily clinical monitoring. Patients will have daily biochemical monitoring. They'll examine the stools for pathogens, as well as doing an unprepared flexible sigmoidoscopy and biopsies to assess for the severity of the disease, and they'll characterise that according to the Mayo severity scoring. And radiologically, we used to get abdominal X-rays. They're still in the guidelines to get radiological support.
No, there's still a place for that.
Yes, although I think most people now are just replacing that with a baseline CT scan in many places.
What's the CT giving more than the?
So because now the vogue is, well, certainly the vogue should be, in terms of endoscopic assessment, should be towards safety. So to not proceed up through inflamed bowel. You can gauge the severity, but you can't gauge the extent of the disease. Now, the abdominal X-ray was quite good for demonstrating if there were areas of toxic megacolon, but maybe didn't give you sort of like an ideal sort of roadmap. Whereas with the CT scan, you can see more accurately the extent of the colonic involvement.
And you might see very subtle perforations earlier, I suppose.
True.
And obviously, if there's a tumour, at the same time, coincidentally, that I suppose is a rare but important phenomenon. We've done the hydrocortisone, 3 days. Things are not getting better. The patient's not improving. And what's the next therapy that you see physicians using?
The next therapy really comes down to, there's usually a sort of a junctional point at the 3 days when the physician should team up with their surgeon and assess the patient together. And the decision at that point is whether or not they think it's suitable to proceed towards medical rescue therapy, and I can come on to that in just a moment, or instead to go towards surgery. Now, if they feel that the patient is stable enough to sort of proceed with medical rescue therapy, well, the physician will try either IV cyclosporine or infliximab. And I think, once you've embarked on either of those, they usually jointly will set a limit of, 1 week, that by that point they will deem whether or not the patient has actually thrived or failed, upon which surgery is indicated.
Right. Okay. So that's
if not
been
before.
a try. They usually try one or the other. They won't go for infliximab and then cyclosporin.
No, that's not to be done. The double immunosuppression we've seen has been related to extremely high levels of morbidity. So
what sort of morbidity?
Well, septic morbidity from the procedure. So
right.
Multi-organ problems afterwards. So it's frowned upon to sort of try doubling back the and crossing over to the alternative one. If a patient has failed, then it's indicated to pursue.
Okay, so we've now got a patient who's failed on the rescue therapy, and surgery's been accepted by the patient in order to get them well. I must say, when I was doing more of this, when I was younger, I used to think this was almost the best operation I ever did. I could change a dying patient into a very well one within the space of 1 or 2 days, and I expect you feel the same when you have to do it. And we're now talking about the technique. You've sort of hinted earlier.
Well, just before we come to that, because I agree with you entirely surgically, but it is also a time for the patient that actually often feels as though it's fraught with failure. And very often they've been hoping to avoid that position throughout. And I certainly, I don't know, you will remember it well, that those conversations that you have with patients beforehand are very difficult, because you're trying to talk them round to a position of safety, that they need this operation for good reasons. They don't want to hear that very often. They have many questions, not relating just to the operation you're describing, but also what happens next. Pouch surgery, it's a huge amount of information to offload on somebody when they're physiologically quite weakened through the disease and very often emotionally.
So do you say to them, I'm not going to talk about pouch surgery at the moment. This is the rescue surgery to get you well enough to take to the next stage at a later date?
Usually what I do is I say that, we've approached the situation, there's really little choice here in terms of getting you better, and I do usually sort of talk to them if they need to talk about pouch surgery. I usually ask the stoma nurses, we're lucky here to have them double up as pouch nurses in certain areas, and they will often go up and speak to the patients as well, trying to maintain the focus on subtotal colectomy. But I think, again, an important point is to put in as many visits as you can beforehand in order to actually, for the patient to feel more comfortable going into the surgery.
Now, you've done all that. The surgery's starting. What sort of proportion do you think up and down the country of patients are getting this done laparoscopically, at least initially? But
it's from the work that we've done, again, with the National Administrative Databases, until about 4 years ago, it was still quite low. And by low, I meant under 20%. Now, it'd be interesting to see how much it's actually improved.
You think it probably has improved, but
I think it probably has improved somewhat, but I doubt whether or not there have been dramatic changes, actually, Peter, because I think a lot of that low number correlated to how the services are organised.
How often are you being asked to do elective surgery at a later date on patients who've already had a full-size laparotomy? I mean, I'm sure that makes it more difficult. We know it does, but I mean, do you see that quite often? So
with the external referrals, it is still quite often the case, to be honest. Internally, we myself and a colleague, have run a rota. Two colleagues, we've run a rota whereby we've done these cases ourselves laparoscopically, but elsewhere, I think it's still very common that patients have an open subtotal colectomy. Okay, well, whether it's laparoscopic or open, what are the fundamentals of the technique at this point? You're trying to save a patient from basically dying. What are you thinking? Interestingly, with the laparoscopic approach, the ACP guidelines, which were published last year, we stopped short of sort of being too didactic about laparoscopy, and we suggested that patients, should have some choice towards the surgical procedure, but there are certain indications where it might be dangerous, such as perforation or toxic megacolon, and certainly patients shouldn't be delayed in order to get laparoscopic surgery. Certainly with the laparoscopic approach, I think sort of some of the key elements for me, I do use a sort of multi-port laparoscopic approach. I take the vessels internally, laparoscopically. I leave the omentum. That was one thing that I was taught to do differently when I was an RSO here at St Mark's. You think it's going to be useful to fill the pelvis later? Well, it's interesting. I'll come back to that in our pouch surgery, because I increasingly now leave the mesorectum. I don't use it so much to leave to plug the pelvis, but I think previously it was perceived that there were problems with adhesions that you quite often get with the omentum, and obviously with the laparoscopic approach we see a lot less of that. Some colleagues I know, they do a very close colonic dissection. They leave the mesocolon. I don't. I tend to take. It's a bit quicker to take them further down. It certainly is if you're taking the vessels internally. Yeah. You only have to. But I think laparoscopically has meant that some of them are just some colleagues will just reflect the left and right hemicolon up to a very small central abdominal wound, and then with an energy device extracorporally just stick very close to the colon and cauterize the vessels adjacent to the colon. And how long does this take you compared with a laparotomy? Is it longer? Now I think my timings are the same. Yeah. So the colon's been mobilized, the vessel's been divided. You divided the ileum right up against the cecal wall. Yeah.
to preserve as much as you possibly can. And what are we going to do about the anatomy now? Are we going to be doing a mucus fistula, or
so that's an interesting
stump?
question as well. And again, the evidence base for all of this is virtually non-existent. The choices you have are between stapling off the rectum and dropping it back into the pelvis. That's my least preferred option. That even with a transanal catheter, if you get a blowout,
it's very dangerous. Isn't it?
You can have
really
real
difficult
problems that follow, and you really then get blurring of the planes for your next procedure. So I try and avoid that. The one alternative is to actually staple off and bring the rectal stump to either in the midline or the left iliac fossa underneath the skin and attach it to the fascia, so that if it does blow out, then you can actually open the wound and it'll discharge outwards. It's not without its problems, but that's my preferred option.
You prefer that to a mucus fistula?
Well, I think patients prefer it to a mucus fistula, but I do reserve a mucus fistula for the patients that are really unstable, really heavily immunosuppressed. And there's one group that just technically you run the staple line and the staples aren't fully catching. You can see that sort of, it wanting to open in certain places, and in those I just formalize it as a mucus fistula.
Right. And if you do...
Importantly as well, Peter, when I leave the rectal stump, I also leave the inferior mesenteric vessels as well, because that actually allows, if you are going to do the equivalent of a TME dissection down into the pelvis, then that preserves your planes.
And so that does mean that you're doing a close colonic dissection on the left side where the IMA supplies. The right side probably doesn't matter, and the transverse colon in that sense. Right. So you've now got an ileostomy. You brought the colon out through a small midline incision.
So I bring it out through the same hole that I'm going to use for tacking the rectal stump actually. So the rectal stump. And I'll staple it off at that point, tack the stump to the fascia, and then close the skin over the top. The ileostomy, laparoscopically, I think it's very easy to get very confused at this point. Very often, your ileostomy is so close to your umbilical port, which is where you usually, if you're using a 10mm camera, where you're actually looking through. So it's usually too close up to actually see clearly what's going on. When we looked at the national data, we actually found that there was actually a surprisingly high reoperation rate attached to subtotal colectomy, and I suspect that a significant proportion of those relate to the ileostomy, potential twists or kinks. So certainly one of the things that I do is I usually convert to a 5mm port, 5mm camera at that point, and then that allows some distance between, you can use one of the other ports, the epigastric one, and then you can see much more clearly with some perspective as to the orientation of your ileostomy.
Right, you've got to be very careful it's not twisted.
Absolutely.
Or whatever. And this is we could just talk briefly about your technique for spout ileostomy, because we're probably not going to do that in the second episode. Any tricks there making a good spout? Is it very important to put a little bit of time in at the end of the operation to do that well?
Yeah, I think there are keys to an ileostomy, and you can do a fantastic operation, and then the patient has lots of trouble afterwards if there isn't attention to detail on the ileostomy. Also, the fascial defect as well. That you get it too big, you start to get sort of peristomal herniation. You make it too small, you have patients that just don't open up properly after the procedure, and very often they have quite a protracted period of stay on the ward. Certainly in terms of the ileostomy, I think most of us, Peter, correct me if it was different, but most of us were taught the sort of 5-5-4 technique for a Brooks end ileostomy. The sutures sort of allow some just slightly greater eversion superiorly than inferiorly, so that when the patient's vertical, you'll get sort of the content going directly into the bag and away from the skin.
And the mesentery facing upwards, or?
I do use the mesentery facing upwards. Yes, I do, yeah.
Okay, well, now the patient's better and gone to ITU or high care for a little while. and the change is often dramatic.
Yeah.
And that's where we're going to leave the first episode of this talk with Professor Omar Faiz on ulcerative colitis and the surgery attached to it. In the next episode, we'll be talking about restorative proctocolectomy and the elective procedures that would follow such a patient. Well, thank you very much, Omar, for joining us, and I've learnt a lot.
Thank you, Peter.
We'll look forward to the next episode. Goodbye.